بسم الله الرحمن الرحيم. باسم ابتهاج خليفة عضو مجلس الإدارة بفريق نبض الإمارات، وباسم اللجان المنظمة لهذا الحدث الدولي، نبعث لكم أجمل التحايا المعطرة بعبق الزهور، نرسلها لكم عبر الأثير، شاكرين تواجدكم معنا في هذا الملتقى الدولي لأصدقاء مرضى الشلل الرعاشي الباركنسون، مع نخبة من الأطباء والمختصين في هذا المجال، ومجموعة من الفقرات المتنوعة والأطروحات ذات الفائدة حول الباركنسون، آملين كل الاستفادة وقضاء أمسية متوجة بكل أنواع السعادة. أهلاً وسهلاً بالجميع، وسعادة عظيمة نتمناها لكم مع كل ما سيطرح. وأحول المايك الآن إلى الزميلة شارزي من جمعية أصدقاء مرضى الباركنسون، فلتتفضل.
Good evening, everyone. Hello? Can everyone hear me?
Yep.
I do, Sharji. Hi, good.
I'm very good.
Yes.
Hi.
Hello to everybody.
Hello.
Hello.
I'm Christian. I'm from Romania. Nice to meet you all. It's a great pleasure to be here.
I'm Gauri, and I'm sure Vittoria knows Christian. Christian heads the Educational Committee of International Movement Disorder Society.
European section.
Yes.
It's a very, very influential.
I am very happy to be here. Thank you very much for your kind invitation. I am really very happy.
Because of Christian, we got winter school. Came to King's. Winter school.
Fantastic.
That's great.
It's a good opportunity to share experience and to support education and research. And definitely we will be very, very happy together with Vinod and Ray and others to support whatever there is need. We have a fantastic collaboration. Yeah.
I'm sure, Prof. I think like Dr. Sohail and Dr. Al-Madani will be joining us. I'm not sure whether they're still there. UAE is the one which we need to consider to get, more, the student type of winter school program, summer school program by Movement Disorder Society International.
Yeah, I will be very happy to help in any way in which is possible. Yeah.
Nice to meet you, Professor Christian.
I'm Christian. Yeah, nice to meet you to all. I'm really, really very happy. Very happy.
Good to have you.
Yeah, it's a great honor for me. As I mentioned, we collaborated for years with Dr. Mehta and Dr. Chowdhury. It's really a fantastic opportunity, and it's already for 10, 12 years, and it's really an amazing experience. And congratulations for this forum, which is a good way to get together everything, and all the authorities, the government, the friends of Parkinson, Emirates, and all the societies. Really, congratulations! It's amazing.
Hi,
Good to see you. Lovely to see you.
Good evening, everyone.
Hi,
Good afternoon, sir.
Good evening.
Good evening.
So there you go. Now we have two wonderful ladies there. I think we should switch off our videos. And number 3 there as well, Charlie. My God.
So we are good to start. Thank you very much for everyone joining us here today on the occasion of World Brain Day. When we talk about World Brain Day, really talking about brain, talking about millions of years ago when we used to use stone to have fire, and now we are using Zoom, we can actually see each other and we can hear each other. And coming to think of it, how has that been possible? That has been possible through the evolution, through the development of the most important organ, that's our brain. And this year, keeping the theme in mind of Parkinson's for World Brain Day 2020, Friends of Parkinson's, registered in Community Development Authority, is reaching out not only to the millions with Parkinson's, but we are also trying to reach, teach, and ensure that the voice of our Parkinson's patients community is heard and echoed by everyone around the world. Now, before we start the program, I would like to welcome Her Excellency, Dr. Maryam Matar, the founder, the chairman of UAE Genetics Association, I would like to welcome our honorable chairpersons, Dr. Sohaila Rukn, consultant neurologist, Rashid Hospital, Dubai. He's also the president of Emirates Neurology Society. Dr. Abu Bakr Al-Madani, consultant neurologist, Rashid Hospital, Dubai Health Authority, and vice president of Emirates Neurology Society. We have Dr. Gauri Ramanathan, chief medical officer at King's College Hospital, London, Dubai. We have Dr. Vittorio Iantorno, clinical lead department of neurology, King's College Hospital, London, Dubai. We also have our guest speakers today. We have Professor Ray Chaudhry, we have Professor Christian, we have Dr. Vinod, and we have Dr. Anna. I would like to now pass it on to Her Excellency, Dr. Mariam, to say a few words.
Good evening, everyone. And I'm so happy to have the pleasure to be among all the senior people here. And I hope you are all staying safe, you and your family. And this COVID pandemic will pass smoothly with a better understanding how to deal with such crisis and to provide a better service for our patient and our community. Allow me in the beginning to extend a special appreciation and thanks to Mr. Hudayfa Ibrahim, who is one of the most active member in UAE Parkinson support group. And because of him, we are here, all of us together, trying to send a very strong message to the community and trying to empower our community with some good example and knowledge how they can manage their own disorders. And allow me, I will talk in a very brief way about genetics from a genetic point of view. As you know, I am a physician with a special interest in epigenetics. And we can understand and see the great advance when it's come to epigenetic with any disorders going on in a human body. With the permission from all our panelists, if you allow me, I got a request from majority of the support group that I need to translate in Arabic language, because what they were telling me, Doctora, there is enough information in English language about epigenetic. Could you please in this day consider us in a special way and talk in Arabic language? And I promise my colleague, if there is any detailed information you would like me to emphasize on, I will go through it. The whole introduction, it will be focused on 3 main areas. I'll talk about a very simple concept about genetics, epigenetics, and regenerative medicine in relation to Parkinson. And I'll try to emphasize on area where the patient will be empowered with the right knowledge, where he will understand that he is the one who's taking the lead to manage his case. With the support of us in the healthcare system, without his initiative and his good understanding about his illness, we won't be that of help for them. So allow me to start in Arabic language with the permission from all of you, dear colleague, especially Dr. Sohaila Rukn, who is a senior to all of us. And I'm so proud to have an Emirati physician in such level trying to contribute in this part of the world with his robust accumulative experience in that area. When we talk about genetics, let's emphasize on one specific area. If you have any mutation which might be diagnosed during the investigation process of Parkinson, that doesn't mean you will have the disease or someone in your family will have it definitely. And I'll explain that on a very basic principle about genetics. إذا تخيلنا كلنا إخواني يتكلم باللغة العربية إن اليوم في كل خلية من خلايانا في 46 كروموسوم. هال 46 كروموسوم ناخذ 23 من أمنا و23 من أبونا ونجيب هذيل 46 كروموسوم ونحط في بالنا نقطة إن هاي ال 46 كروموسومات موجودات في كل خلايا الجسم. خلايا العين، الشعر، الأسنان، الجلد، كلها فيها 46 كروموسوم. وهذيل ال 46 كروموسومات عبارة عن DNA، عبارة عن خيط DNA ملفوف على بعض، تقريبا طوله 6 أمتار في كل خلية. تخيلوا سبحان الله. فبالتالي هالخيطين يلتفون على بعض تقريبا 6 متر في كل سيلز، وتكون لنا كل التعليمات اللي تقول حق هاي الخلية كيف تصنع البروتين. من صناعة البروتين الجسم يقدر يصنع الهرمونات، يصنع الإنزيم، يصنع أي مكون من جسم الإنسان. فبالتالي اليوم من خلال فهمنا لهذا الموضوع عرفنا اليوم الخلية في الدماغ، النيرف سيلز اللي موجودة في البرين عندنا فيها فيها كل 46 كروموسوم. بس شو اللي خلاها انها تكون خلية دماغ، ما تكون خلية عين، ما تكون خلية جلد؟ بشكل شرح بسيط، اليوم احنا عرفنا ان الدي ان اي هو المكون الجيني، بعدين هذا اسمه علم الجينات، بعدين جاء علم جديد اسمه علم فوق الجينات، الابيجينيتكس. الابيجينيتكس هذا اللي يتحكم في عمل هذيل الدي ان اي، يقول حق هذه الدي ان اي انت الحين موجوده في الدماغ كخليه عصبيه، لازم تكونين فقط خليه عصبيه. باقي الدي ان اي التعليمات اللي موجوده على الخيط هذا لازم كلها سويتش اوف، كلها تتسكر وما تنفتح الا الجزء المسؤول عن اعطاء التعليمات ان هذه الخليه تكون خليه اعصاب. ومن هني قمنا نعرف ان الدي ان اي مو هو اللي يتحكم فينا، ولكن عرفنا ان الانفايرمنتال فاكتور اللي هي العوامل البيئيه تلعب دور كبير في فتح وغلق هذه الطفرات الجينيه. بالنسبه للباركنسون خاصه بشكل خاص، احنا نعرف ان يكون في نقص في ماده اسمها الدوبامين، والدوبا وهذه الاشياء كلها مهمه لعمل الخليه ان ما يكون عندنا اعراض للباركنسون. فبالتالي اليوم علم فوق الجينات عرفنا مبادئ تحكم البيشنت بتطور حالته، سواء كانت العوامل لها خص في أنا مباشرة أتحكم فيها، أو عوامل بيئية خارجية أنا ما أقدر أتحكم فيها، مثل التلوث في البيئة، الهافي ميتالز، المعادن الثقيلة اللي ممكن تبند هذه الطفرات وتخلي الخلية ما تشتغل عدل. ليش مهم ان اليوم احنا كأصدقاء الباركنسون ان نعرف هذا الشيء؟ قبل كانوا يقولون ان اضطرابات الباركنسون ما لها خص في الجينيتكس. اليوم العلم اثبت لنا ان اي اضطراب في جسم الانسان، اي مرض، الضغط، ارتفاع السكر، الكانسر، كلها لازم يكون في خطأ او طفرة جينية او خلل على مستوى الدي ان اي وعلى مستوى الابيجينيتكس عشان هذه الخلية ما تشتغل عدل. فبالتالي اليوم لازم نفرق بين المرض الجيني، اقول الاضطراب الجيني والاضطراب الوراثي. شو الفرق بينهم؟ الاضطراب الجيني هو نوع من الطفرات الجينية اللي نشوفها عند الشخص المصاب بنوع من العلة أو علامات العوق هذا، ولكن مش موجود في الوالدين أو أحد الوالدين. أما المرض الوراثي اللي له علاقة سواء بطفرة الباركنسون أو طفرات الأمراض الأخرى، إن لما نحصل هذه الطفرة لدى المريض ونحصلها في أحد الوالدين أو كلاهما، هني نقول ترى أنت العوق اللي فيك بسبب طفرة جينية وارثنها من أحد الوالدين أو كلاهما. فبالتالي لازم نعرف أن أغلب الحالات إلى اليوم اللي كانت عندها الفرصة أنها تدخل في البرامج البحثية كانت عبارة عن اضطرابات جينية وليس اضطرابات وراثية، بمعنى أن ما حصلوا نفس الطفرة لدى الوالدين أو أحدهما والمريض هذا شو أهمية هذا الشيء؟ هذا يلعب دور كبير في طريقة العلاج. وزملائنا طبعاً أستاذنا دكتور سهيل ودكتور أبو بكر وزملائنا دكتور بنوت وكلهم هم أخبر بالنسبة لطريقة التعامل مع هذا المرض. احنا من الناحية الجينية يكون دورنا أكثر تشخيصي ووقائي. وقائي إن احنا ندرس شو هي العوامل هذه اللي خلت اليوم مريم تطلع عليها أعراض الباركنسون، ولكن أختها ليلى ما يكون عندها أعراض الباركنسون، من خلال دراسة العوامل البيئية المحيطة والعوامل الخارجية اللي كلها تنزل تحت عنوان مسمى علم فوق الجينات أو هو الإبيجينيتكس. وآخر نقطة أريد أذكرها بالنسبة للريجنراتيف ميديسن. اليوم إحنا نعرف ونسمع كثير عن الستم سيل، الخلايا الجذعية، وكثير من الناس يقولون دكتورة ليش ما تشاركونا في هذه الدراسات؟ وفي أمريكا قاعدين يعالجون الناس وفي اليابان يعالجون الناس. لازم نحط في بالنا نقطة رئيسية في هذا الموضوع. اليوم عشان إحنا كأطباء نعطي أمل، لازم يكون أمل حقيقي وأمل معتمد، وطريقة من التدخل العلاجي اللي آثارها السلبية تكون وايد أقل من آثارها الإيجابية. فبالتالي اليوم بالنسبة للعلاج بالخلايا الجذعية بالستم سيل، الحمد لله كثير من الدراسات تبشر بألف خير، وهذه واحدة من الأمور تعطينا معرفة كبيرة إن كل واحد فينا كيف يقدر، إذا ما قدر يساعد نفسه يساعد الآخرين. هني يأتي دور الفولنتيرز اللي هم المتطوعين في الأبحاث، في الريسيرش اللي تستوي في العالم كله. فبالتالي اليوم حتى لو كان إحنا نتكلم عن دولة الإمارات العربية المتحدة، إذا ما عندنا هاي المراكز البحثية المتخصصة في علاج الباركنسون أو أي مرض يعنى بالريجنراتيف ديس اوردرز، نحاول عن طريق الطبيب نقول له دكتور أنا مستعد أني أنا أدخل في هذه الدراسة اللي خلينا نقول في أمريكا، والدكتور المختص هو بيعرف كيف يدليك وبيضمن أنه يحتفظ بحقوقك وأنت تكون جزء بالخير الكثير للإنسانية. فبالتالي بالنسبة للعلاج بالخلايا الجذعية تبشر بألف خير. أخيراً بالنسبة ل something called pharmacogenomic، قبل كانوا الناس يعطون العلاج، يعني اليوم أنا أعطي مثال على مرض الضغط، البلاد بريشر قبل كنا نعطي أول لاين بيتا بلوكر، كالسيوم شانل بلوكر، AC inhibitors. الحين مع الفارماكوجينوميك قمنا نسوي شيء اسمه جينوتايب، نفحص المريض نعرف شو نوع الإثنيسيتي اللي هو عروق الإنسانية، وبناء على التجارب اللي صارت يعني يقولون اليوم إذا كان واحد أفريكان إثنيسيتي الكالسيوم شانل بلوكر تشتغل معاه أفضل من أول جرعة والضغط يصير له كنترول. الناس اللي عندهم كوكيزيان يعني الأوروبيين نبدأ معاهم بالبيتا بلوكر. ونفس الشيء اليوم العلم بالنسبة للباركنسون قاعد يتقدم بشكل كبير في الفارماكوجينوميك، وقاعدين يحاولون الشركات الأدوية العريقة توجد لنا أدوية تكون مخصصة للشخص المعني حسب عروقه وحسب الخارطة الجينية والجينوتايب ماله. إضافة إلى نقطة كثير مهمة، أن اليوم قريب العاجل الحمد لله مش بس مع الضغط، حتى مع السكر، اليوم مع أنواع عديدة من السرطانات كان الكيموثيرابي علاج موحد، اليوم لا، قام فيه كثير من التخصص باختيار الدواء على أساس الجينوتايب للبيشنت، ونفس الشيء للباركنسون. ولكن عشان إحنا نوصل لهذا المستوى من التقدم العلمي باختيار الدواء الصحيح للشخص المناسب، لازم يكون في عندنا نوع من التعاون الدولي من خلال تشجيع مرضانا يدخلون في الكلينيكال ريسيرش. فبالتالي الفولنتير in the clinical research you can add، تقدرون تضيفون كثير لهذه القاعدة اللي بتساعدنا نعالج المريض مش فقط من الكوكيزيان ولا في أمريكا ولا في بريطانيا، ولكن من كل أجزاء العالم، ومن خلاله نقدر إن احنا نوفر العلاج بأفضل طريقة ممكنة. وآخر شيء something called nutrigenomic اللي هم nutrition بس له علاقة بالجينيتكس. يعني اليوم مع الباركنسون عرفنا إن في أنواع معينة من الفيتامينز، من الأنتي أوكسيدنت،
Thank you, Dr. Mariam. Thank you so much. We would like to now call upon Dr. Abu Bakr Al-Madani to say a few words.
Excuse me, is it fine if I can excuse, because I have another session about reproductive health and genetics. It's for Ministry of Community Development. It will start at 8 o'clock.
Thank you so much. Thank you so much, Doctor.
Thank you. Wish you all the best. And again, it's a great pleasure for me to be among all of you, and looking forward for your continuous support, and looking forward to have a proper clinical research in King's Hospital in Dubai in collaboration with UK. Thank you very much and wish you all the best.
Looking forward. Thank you so much. Have a good evening.
Thank you. Thank you.
Dr. Abu Bakr Al-Madani.
Yes. Hi, how are you guys?
Very good, Doctor. How are you?
Thanks.
Over to you.
Okay, so I'll speak in Arabic first, then I'll translate in English.
Perfect.
Okay. بسم الله الرحمن الرحيم. بالنيابة عن جمعية أطباء الأعصاب أشكر الدكتورة ليلى بحضورها في هذا اليوم، وأشكر كذلك الأطباء والجمهور للحضور في هذا اليوم المهم، اليوم العالمي للدماغ. لقد سعينا في جمعية أطباء الأعصاب في السنوات السابقة كعضو أو كنائب رئيس في إنشاء جمعية لأصدقاء المرضى. وتم إنشاء جمعية أصدقاء مرضى التصلب اللويحي، وقريبا تم إنشاء جمعية أصدقاء مرضى الباركنسون عن طريق المريض أو عن طريق الأخ حذيفة. نأمل من خلال هذه الجمعية أن تكون نواة لمساعدة مرضانا في الإمارات بالذات وفي العالم خاصة. في هذا اليوم نأمل أن نرسل رسالة للمرضى وللجمهور، رسالة بسيطة عن مرض مرض الباركنسون وعن علاجه وعن علاجات الحديثة الموجودة في الوقت الحالي. Now I'm going to turn in English. On behalf of Emirates Neurology Society, I thank everyone for attending this meeting. I thank also Dr. Leila for her speech. We were striving for the last few years to have a patient society. We succeeded to establish patient society or patient society for multiple sclerosis. And recently, by help of our colleague Hudayfa, we were able to establish a patient society for Parkinson's disease. We are hoping with this society to be a core for establishing more and more updates in Parkinson's disease and more help for the patient and the society. I'm hoping for this day especially to elicit or solidify what do we mean by Parkinson's disease or Parkinsonism? And we have a plethora of experts who can present us in details about Parkinson's disease. And I'm hoping the talks to be in grade 4 level so everyone can understand in detail. And thank you very much.
Thank you so much, Dr. Abubakar. Just wanted to correct, that's Dr. Mariam, whom we spoke with earlier.
Dr. Mariam, sorry.
Dr. Mariam. Dr. Gauri, over to you.
Thank you very much, Shazi. Now, as the Chief Medical Officer and actually a member of the UAE Genetic Disease Association, it is an honor to be part of this great forum and initiative. As you all know, World Brain Day 2020 is dedicated to raise awareness for Parkinson's disease. It affects all ages, it affects a huge number of people. And unlike the West, the region needs more national data on the disease prevalence. And this is an area that needs addressing. Friends of Parkinson's UAE is such an important initiative to address and raise awareness of this disease. King's College Dubai is fully supportive of this. And indeed, we're very fortunate that we have our Advanced Parkinson's Center here in Dubai, which is directly linked with King's College Hospital, London, which is the Parkinson's Center of Excellence over there. We manage Parkinson's disease. Maybe some of you have already come through to visit our own neurologist. However, with advanced Parkinson's disease, this has only been available in the Middle East now, offering life-saving infusion therapy by the very experts who are here in our forum today. Professor Ray Chowdhury, who will be joining us very soon, who is committed and supporting research into Parkinson's disease. Dr. Vinod Mehta, our consultant interventional neurologist, who only recently was at King's Dubai and treated a very severe case of Parkinson's disease, a patient on a wheelchair, and had been for the last 2 years. And within 48 hours, the patient was able to walk and eat independently. I would like to thank the Dubai Health Authority, the UAE Genetic Disease Association, Emirates Neurology Society for this wonderful initiative in bringing forward and putting us up on the bar. Thank you very much.
Thank you very much, Dr. Gauri. Thank you so much. Dr. Vittorio.
Thank you very much. It's an absolute honor to be part of this webinar. Parkinson's disease, briefly, is a chronic neurodegenerative brain disease that unfortunately affects more than 7 million people worldwide. And it's estimated that the prevalence will continue to increase, and we can probably expect the trend will continue in the next few decades to reach probably 12 million patients by about 2050. It's a debilitating disease. Few symptoms, characteristics of the disease are tremors, slurring speech, and stupid posture. Again, it's an honor to be here. This very World Brain Day is and must be dedicated to raising awareness to improve the lives of those with Parkinson's disease and their caregivers. Again, it's a pleasure to be here with some of the world's leading neurologists and Parkinson's disease experts to support the World Federation of Neurology and International Parkinson and Movement Disorder Society, as we need and must move together to end Parkinson's disease. We have got an incredible panel here. Guest speakers are world-renowned experts. And it's my pleasure to introduce our first speaker, Professor Cristian from Romania. Professor Cristian doesn't need any major introduction. He's the head of Department of Neurology in Brasov, Romania. He's lecturer of neurology at the Transylvania University, and he has accomplished he has got many feathers in his cap. Is chair of the Educational Committee of International Parkinson and Movement Disorder Society, the European section. He's member of the International Executive Committee of the Movement Disorder Society, member of the International Executive Committee, Movement Disorder Society, the European section. I'll leave the microphone to Professor Christian, and the topic will be what is advanced Parkinson's disease. Professor Christian.
Good evening to everybody. Can you hear me?
Yes, we can.
Okay, thank you very much. And can you see my slide?
Yes, we can.
Okay, fantastic. So good evening to everybody. Again, it's a great pleasure and honor to be here with all of you in this evening. Congratulations for such a nice celebration of World Brain Days dedicated to Parkinson's disease. I would like to thank to Friends of Parkinson, United Arab Emirates, Government of Dubai, Community Development Authority, Dubai Health Authority, Emirates Genetic Disease Association, Emirates Neurology Society, King's College Hospital, London, Dubai, for inviting me to this very special session. It's wonderful to see such a joint important forces for these important brain days. Thank you very much, Dr. Suhal Arukun, Dr. Abubakar Al-Madani, Dr. Govri Ramanathan, Dr. Vittorio Lantorno. Thank you very much, Her Excellence Dr. Mariam Matar, and all together for launching this forum. And this is crucial and very important to celebrate the Parkinson's Disease Day. We have a special relationship with the King's College Hospital, with Professor Chowdhury, with Dr. Mehta, and I'm really very honored by this kind invitation. Our relationship started like 12 years ago back with collaboration, research, educational activities, and many, many projects. I would like to extend the support for education and research for this part of the world. So you have my and our fully support. And I think this is a wonderful opportunity to start to look for different things that could be done. And again, it's fully support and strongly support for education and research. What I'm going to do is to talk about an important topic of advanced Parkinson's disease. Parkinson's disease is associated with a clinical course of variable duration, severity, and a combination of motor and non-motor features. There has been a few studies about clinical progression or long-term outcomes. The progression of motor symptoms in PD is closely associated with the progressive neurodegeneration in neurostriatal pathways. In addition, multiple other factors contribute to this progression of global disability. There is current therapeutic strategies in early Parkinson's disease, which have been relying to the neuroprotection and amelioration of the Parkinson's disease patients. Once the motor fluctuations appear and axial disability, we are starting to think about the advanced Parkinson's disease, which has a different definition in the literature. Here are just depicted a schematic representation of the clinical course of PD. The diagram summarizes the principal hypothesis behind studying clinical progression and long-term outcome in PD. Past research has intensively investigated the factors influencing disease development in this part in the left, which was partly driven by the hope that neuroprotective treatment will become available. But it was not the case. On the contrary, the clinical trajectory of the PD after disease manifestation in this right part has remained understudied. PD is a very heterogeneous disorder, as we all know, and only subgroup of patients develop severe disease and disabling complications. This would make it possible to provide individualized prognostic information to patients soon after the diagnosis is established, and hopefully to improve outcome by addressing modifiable factors of disease progression. Why we should better define advanced Parkinson's disease. The concept of advanced PD remains somehow controversial in spite of extensive knowledge of the natural history of the motor syndrome of PD. The terminology has been confusing sometimes with different varying nomenclature. the World Health Organization classification of disorder, the ICD coding system that we are using worldwide, currently has no definition for advanced Parkinson's disease, although many therapies such as levodopa infusion therapies or apomorphine infusion or deep brain stimulation are indicated for advanced Parkinson's disease. Who will be affected by the early identification of advanced Parkinson's disease? The need for a robust definition of APD is important for several reasons, especially for people with PD, as the current uncertainties can cause problems with prognostic issues. Critically, it is clear that the prognosis and outcome of the course of PD cannot be generalized, and individualization, an important concept of the personalized medicine strategy, is crucial. In addition, the term advanced is fully accepted by many patients who, in spite of the disease duration of 10 years or more, may be active, independent, as well as cognitively reasonably intact. Clinical experience suggests that many patients resent being called advanced, particularly if they are able to be still working and socialize with some limitations. So who will benefit? The patients. Who will benefit? The healthcare providers and healthcare professionals. There are several issues that complicate the current attempts to define advanced Parkinson's disease. Traditionally, long disease duration has been the standard method and anchor by which advanced Parkinson's disease has been defined, although in most cases, PD duration is really a secondary marker, as we know from the practice. The length of the disease duration for PD to be considered as advanced PD has been based on the duration of the honeymoon period. We know that the patients are coming and we are giving treatment to them, and they are very happy and we are very happy. And this is the period of honeymoon, and after that of the stable PD, and emerge afterwards a couple of years of 5, 7, 8 months, depending, even for after 2 years when the motor complication and afterwards the dyskinesia appears. Disease duration alone, therefore, cannot truly map whether PD is advanced or not, and certainly there is no inevitability about dementia at 20 years PD that has been suggested in different studies. The concept of advanced Parkinson's disease, the APD, has been investigated in several studies with varying methodologies that are depicted in this cartoon, ranging from retrospective audits to expert opinion and Delphi system-based studies, usually using disease duration as one of the anchors as shown in this table. I just highlighted the 3 studies of Professor Angelo Antonini, Professor Perodin, and Professor Lupin that I'm going to discuss in more details in the next couple of minutes. It is clear that our current concept of APD is plagued by several problems, including unclear transitional milestone when stable PD becomes unstable PD or early PD becomes advanced PD. The syndromic nature of PD, multi-neurotransmitter involvement, because we know that is not just dopaminergic problems, motor and non-motor subtypes of PD, variable and unclear progression patterns of motor and non-motor symptoms, and recent mapping of several non-motor symptoms marking prodromal PD, make a clear definition of APD inaccurate, as largely the concept is underpinned by disease duration. The complex phase of PD would encompass the basic concept of the complex of origin of PD, as well as the heterogeneity of its clinical presentation. The burden of advanced Parkinson's disease, as always, the patient's perspective is the most important, and this is the study that was published 10 years ago by the King's group, led by Professor Chowdhury, and Professor Politis was the first author. The study of 265 patients with PD. Participants were asked to name the 3 most troublesome symptoms they experienced in the past 6 months. So it is crucial to ask the patient, what is your most troublesome symptom? For the early PD group that was defined at less than 6 years of PD symptoms, the most bothersome symptoms were slowness in half of the patients, tremor, stiffness, and afterwards pain and loss of smell and taste. In advanced PD, defined by more than 6 years of PD symptoms, the most bothersome were defined by the patients by fluctuating response to medication, mood, drooling, and afterwards sleep, tremor. So in other words, it's not just a motor part of the Parkinson's disease. There are many non-motor symptoms that are bothering the patient. This is an important study, the CHEPA study, that was a multi-center that were performing using Delphi method. Delphi method means that there are a number of experts that are having a set of data, and based on their best expertise, they are having different assessment of different topics. And afterwards is a consensus, and after that there are a number of the rounds, and at the end is a document that is based on their assessment. So 5 different Spanish centers, experts in movement disorders and PD, formed a scientific committee. They reviewed the literature and the question reflecting some of the proposed feature for defining APD, clinical characteristics and treatment was created. And afterwards, a list of clinical characteristics was circulated, and the number of activities afterwards. And this is important. Another topic, Professor Angelo Antonini and co-workers developing a consensus among movement disorder specialists on clinical indicators for identification and management of advanced PD in a multi-country Delphi panel approach. What this study was showing, the modified Delphi process consisted in 4 stages. Panelists were assigned, the panelists were defined as a top expert, were assigned a unique anonymous identifier and provided with an individual web survey link. So this was Delphi round 1 and 2. Stage 1 involved the recruitment of the Delphi panelists. Afterwards, stage 2 and 3, an anonymous web-based questionnaire was administered to the Delphi panelists, and the stage 4, involvement in person meeting to facilitate achievement of consensus through discussion, followed by anonymous aggregated polling data and ranking activities. A total of 17 leading movement disorder specialists participated in this process, and the panel included movement disorder specialists with extensive experience, as I mentioned, in treating patients across the PD severity. The final consensus on clinical indicators of suspected advanced PD and eligibility for device-aided therapy, overall consensus are depicted in this cartoon with 15 clinical relevant indicators, some of them 6 with motor symptoms, 5 of them with non-motor symptoms, and 4 with functional impairment as indicators of suspected of APD. These are the items that are depicted. The motor part was with 6 items, moderate level of troublesome motor fluctuations. This motor fluctuation could appear early in the disease treatment, even after 2 years. They are usually mild, and afterwards, at 5 years, we know that half of the patients are having the motor fluctuations. More than 2 hours of the day with off symptoms, then we need to carefully assess the patient with these parts of the off. More than 1 hour of the day with troublesome dyskinesia, moderate level of dyskinesia, troublesome dysphagia, especially when the patient have the risk of aspiration, overall levodopa doses more than 5 times per day. From the non-motor part, there were potential items like mild level of dementia, non-transitory troublesome hallucination, moderate level of psychosis, non-motor symptom fluctuation. In other words, the patient could have in the morning different non-motor symptoms like pain, like fatigue, and afterwards, after the treatment or in a different part of the day, would have a better evaluation. Moderate level of 9-time sleep disturbances. And for the function, there were repeated falls, more than 1 fall, despite optimal treatment, needs help with daily activities, at least some of the time, not able to perform complex tasks most of the time, and moderate impairment mobility. And afterwards, the final consensus were saying that motor part should have 5 items, and this is the final the final document with troublesome dyskinesia and off periods, at least 2 hours of off time during the 24 hours, off period postural instability that could be followed by falls, dystonia with the pain, freezing of gain during off, and from the non-motor symptoms that are many, and Professor Chowdhury opened the field and highlighted, and we learned that how important is this field. Nighttime sleep disturbances, and from the function is limited to activity of daily living. Moving on to the specialists determined that in general, patients who have a good response to levodopa, patients 70 years age or more, and patients who have good cognitive function were considered general definite or probably good candidates for all three device-aided therapy that I mentioned. Observe PD is another tool, a cross-sectional international observational tool that was conducted recently with more than 2,600 PD patients globally in 18 countries in 128 movement disorder centers. The goal of this analysis was to determine the proportion of advanced Parkinson's disease versus non-advanced Parkinson's disease patients attending specialist PD clinics and to demonstrate the clinical burden of APD, motor and non-motor symptoms, activities of daily living, and quality of life endpoints were assessed. The correlation between physician global assessment of advanced PD and advanced PD criteria from a consensus of international group of experts of Delphi criteria for APD were evaluated. These are depicted somehow quite the same items, a little bit more items that was previously in the study that I mentioned. Troublesome motor fluctuations, severity level should be moderate or severe. So the patient, if the patient have mild motor fluctuation, this could be managed from the different drugs. Off time should be more than 2 hours per day. Nighttime sleep disturbances should be like moderate or severe. Troublesome dyskinesia per hours for working days should be like more than 3 hours. Presence of non-motor fluctuation, off time at least every 3 hours, more than 5 daily dose of levodopa. So in other words, this is showing us that we need to improve the levodopa treatment for advanced Parkinson's disease in order to optimize the treatment for this patient and the benefit and improve the quality of life. Falling, dementia severity should be moderate, or severe psychosis should be moderate. So this study show us that there were some agreement and some disagreement between the scores in different centers, but overall, this definition were working very well. So this is an instrument that could be used in the clinical settings for all of us. A clear lack of clear definition of advanced PD, as I mentioned, together with absence of gold standard tests, make diagnosis and management of the symptoms challenging. In patients whose symptoms are not adequately controlled or oral medication, the likely changes with gastric emptying may require appropriate utilization of device-aided therapies like subcutaneous apomorphine and levodopa, carbidopa intestinal gel, or deep brain stimulation. Managed PD is an instrument that is very useful in the clinical practice. Informed decision to aid timely management of Parkinson's disease is the extended time managed PD. And this tool aimed to support health professional decision-making for the timely management of PD symptoms based on comprehensive evaluation of the frequency and severity of the motor, non-motor, and functional symptoms. I would like just to highlight that not just motor symptoms, not that is important, are very important non-motor symptoms, and obviously the functional symptoms of the Parkinson's disease patient. This managed PD tool have two sections. The first is the screener for inadequate control on current oral medication. In other words, we need to optimize the treatment for the PD patient, and we need to check the taking oral medication more than 5 times per day, having more than 2 hours or off time per day, having unpredictable fluctuation of motor symptoms, having troublesome dyskinesia, having limitation in more than one activity of daily living. If answer is no to all the questions in this section 1, the patient is classified as category 1. If answer is yes to any question in section 1, then the patient continues to section 2. And this part determines eligibility for evaluating device-aided treatment for symptom control. Here are depicted the items that are important for this section 2: unpredictable motor fluctuation, off-time periods, troublesome dyskinesia, non-motor off, activity of daily living impairment, force within the past month, dystonia with pain, impulse control disorders. And if severity and frequency of any domain in section 2 higher than established threshold, will be categorized under section 2. How to evaluate the reliability and validity of management tool. There were the web-based survey, and this was the instrument implemented before the pandemic, because nowadays we are used to the internet and the technology. Right now we are very happy to join forces together through the Zoom. 20 Parkinson's disease patients, especially from 15 countries from US and Europe, were identified based on their expertise in comprehensive treating advanced PD. A web survey was completed by each panelist, and after that, each specialist scored each vignette evaluating the frequency and severity of motor symptoms, non-motor symptoms, and functional impact along with the current medication. Based on their own clinical judgment, PD specialists rated the treatment management approach for each assigned vignette, and open-ended feedback was solicited on the clarity of the vignettes as a tool. At the analysis, there were a descriptive and scoring analysis of responses that were completed for each vignette. The degree of agreement among PD special raters on the severity of each vignette was evaluated, and intra-class coefficient weighted kappa statistics were calculated for concordance. In other words, this term means that should not be an agreement of 100%, but should be a statistically relevant agreement in order to have the robust tool that should be used in the clinical settings and in the research as well. Cognitive interview feedback from 5 of the panelists was evaluated for common 10 or identified issues. There are depicted here the strength of the managed PD tool is a robust quantitative and qualitative data from this panel of leading PD specialists from multiple countries, and the indicators in the tool are grounded in the findings of Delphi-based consensus panel, including leading international PD specialists that have demonstrated acceptable accuracy in real-world settings. So this is the instrument that I will advise use in the clinical settings in order to assess the patients to have the best potential definition for advanced PD and to offer to them the best treatment possible. The CHIPA questionnaire was, as a definition, the presence of severity disability requiring help for activities of daily living, motor fluctuations with limitations or inability to perform activity of daily living, severe dysphagia, recurrent force, or dementia. In a previous prospective nationwide and after a 3-round of Delphi study, so again, this Delphi study is used as a standard nowadays. This was used in Spain, where this study, CHDEPA questionnaire has been validated. And as is shown in this table, in all cases where the CHDEPA questionnaire classified patient as advanced Parkinson's disease, scores of study rating scales of QNR, non-motor symptom scale, and GCPD were significantly higher than in patients classified as non-advanced. Because of the criteria like the definition in the CHDEPA questionnaire have not been found in previous published studies, it was proposed to accept the neurologist's clinical judgment as the best available benchmark, as a gold standard, to determine the presence or absence or advanced Parkinson's disease and to classify the PD stages as mild, moderate, advanced, and late stages. Most of PD patients are cared for in their own home, and spouses or caregivers are the main informal caregivers. Caring for a partner or family member with a progressive neurological disease has been recognized to negatively impact a caregiver physical, emotional, and psychosocial well-being, and with increasing risk of psychiatric morbidity and persistent distress. Moreover, caregiver burden increases as the patient disease progresses, with speech difficulties and cognitive deterioration associated with poor caregiver quality of life. Regarding the source of knowledge of the Mumbai Center managing the advanced treatment options reported by each treatment group, there is the main source of information were community neurologists in 25–40% of the cases, while patients' association as source of knowledge represent a small percentage. Among patients receiving different dispositive-aided therapies, the main reason that convinced them to switch from one to another were reduced the quality of life that is depicted in this cartoon. Collective physician perspective on non-oral medication approach to the management of clinically relevant unresolved issues in PD. This is a consensus led by the Professor Perodin. Caregivers rated their current life status at good in this study or very good in 70% of the cases, while such rating were reported only by half of the caregivers and 40% the standard of care. Navigate PD is another tool that is very important. It's an educational program that established to supplement existing guidelines for PD refractory therapies. It involved 100 experts from 30 countries, overseen by international steering committees of 13 movement disorder specialists, and draft guidance was present at international and national meetings and revised based on feedback. The key take-home points were patients require levodopa more than 5 times daily, who have severe troublesome off periods. It means that more than 1–2 hours per day, despite optimal oral transdermal levodopa or non-low levodopa-based therapies, should be referred to for specialist assessment even if disease duration is less than 4 hours. I would like to highlight the optimal treatment. So we need to offer for our patients the best treatment possible. Cognitive decline related to the non-motor fluctuation is an indication for device-aided therapies. If cognitive impairment is mild, we could use the DBS with caution. There are a number of the clinical evidence showing beneficial effect of device-aided therapies. Just for this definition of advanced PD, I'm not going in details because our colleagues will show you. And the decision perspective on shared decision making in advanced Parkinson's disease, this is a cross-sectional survey study that has been published recently. This is just the highlight that we need to take into account always the voice of the patient. And this is the day today of 22 of July, in which is the World Brain Day is dedicated to the Parkinson's disease patients. This is a tool, just to come to the end of my talk, that was developed in UK. The complex Parkinson assessment tool, which is something that we could use, as we should use, that comes in the form of a tier of pad and can be used, as I mentioned, in consultation with our PD patients to identify those who may benefit from being referred to a specialist center for non-oral therapies. Why was the tool developed? The complex PD assessment was developed, as I mentioned, for UK healthcare professional by a working group of UK neurology specialists in collaboration with AbbVie. It has been created to identify patients whose symptoms are inadequately controlled by their oral therapies and who may benefit from being assessed at a specialist center for neurology. Why should we use the tool? as disease progression to a more complex state, because we are talking about advanced Parkinson's disease, quality of life is dramatically reduced. And recent data show that approximately only 90% of the patients with complex Parkinson's, with advanced Parkinson's disease, are currently being treated with non-oral therapies. And with this, I would like to thank you once again for this opportunity. And once again, congratulations for the wonderful visionary strategy that you have with this forum. And I will end up mentioning that fully support from my and our side for education and for research. Thank you very much for your attention.
Thank you very much, Professor Christian, for this beautiful, wonderful, and precise overview of what is advanced Parkinson's disease. To all the audience, we will leave the Q&A session at the end of all topics. Now, before the next speaker, I will leave the audience to Sharzi for a small announcement. Sharzi?
Thank you, Dr. Vittorio. It's an honor to welcome Professor Ray. We have Professor Ray joining finally. He will be talking after Dr. Anna. And I just want to mention special thanks to Abu Dhabi Quality and Confirmative Council for their support. We actually have more than 250 people join in. So thank you very much for that. Thank you. Over to you, Dr. Vittorio.
Thank you very much for welcoming me. I thank everybody, plus particularly the Friends of Parkinson's United Arab Emirates, all the delegates and the faculty. Thank you. Thank you very much.
Thank you, Professor Ray.
Thank you, Sharzi.
Thank you.
Thank you, Sharzi. And welcome, Professor Ray. Now it's my pleasure to introduce our next speaker. It's Dr. Vinod Mehta. Vinod is a consultant interventional neurologist and movement disorders, Estonian Parkinson specialist. He trained at King's College Hospital in London. He has authored and co-authored several papers published in impact factor journals. He serves on several advisory board committees, and certainly is a world expert in treating patients with advanced Parkinson's disease, and is a pioneer in novel device-aided non-oral therapies, including Duodopa, successfully treating lots of patients with advanced Parkinson's disease over a decade, not only in UK, but also in India and in the Middle East, and is one of the few interventional neurologists providing bespoke one-stop interventional procedures. And I'm personally quite honored to have him here in King's College Hospital, London, Dubai, as a visiting consultant. Amongst all treatments and neurological interventions he is able to offer is certainly the novel device-aided non-oral therapies. I'll leave the microphone to Dr. Vinod. He will enlighten us about advanced therapies, quality of life, and new kids on the block. It's a very interesting topic. Microphone to you, Vinod.
Thank you, Dr. Vittorio. Thanks for your kind introduction. And also, I want to thank Her Excellency Dr. Mariam for joining us today, and also all chairpersons, Dr. Gauri Ramanathan and Dr. Abu Bakr and Dr. Sohail, and of course, esteemed chairperson, Dr. Vittorio, and also my other speakers, Professor Ray Chowdhury just joined in despite of his busy commitments, and Christian and Dr. Anna. So I've been asked today by CDA just to focus on quality of life, a patient's view. So just want to make sure this is actually aiming for patients, carers on a Parkinson's Day, on a World Brain Day with the Parkinson's theme, not aimed at a scientific community. So please, excuse if it's too much of, if it's not and too much of science. So I'm going to make it very basic. What is quality of life from a patient's perspective? Why is it relevant? I want to take you through. This is actually what one of my patients told me. when I first saw him in King's, Dubai. I took his permission to reveal his history. These are the words straight from the patient's mouth. I am 29-year-old man, doctor. All as my life, I was full of Superman energy. All started with stiffness in my right shoulder, followed by clawing of toes, painful cramping. Then I've been told to see orthopedic surgeon. 8 months of intense agony, anguish, unruly, unyielding pain. Can you imagine the way he described his pain? I've been asked to see a pain specialist. One fine morning, I woke up with my joints locked in. My foot is in its stride. My toes clouding, started shuffling. My wife on one side, my kids on the other side held me. And I remember my little one saying, "Daddy, I can be your walking stick." Finally been told, doctor, I have YOPD, young onset Parkinson's disease. I can live with YOPD. I can live with Parkinson's, not great, but livable. But the fatigue is unbearable. I'm good for about an hour or so at a time. And between the lightheadedness and the fatigue, end of the day, sometimes I get unbearable pain. I am wasted. I've been told to see a psychiatrist and start on antidepressants. This is actually the history I got from a young patient who is in his late 20s being told. You can see, I was the 7th neurologist he was seeing. So he made it very clear to me that, hello, my dear consultant, it's not the Parkinson's I'm worried about. Don't tell me it's all Parkinson's. It's the fatigue and pain is the one which is bothering me. So he gave me a hint. He gave me a hint saying that what needs to be addressed. So quality of life for this patient, for example, is not what we think. It's what we need to address, what he exactly wants to. Number one, I just want to go back, quick rewind 200 years ago, James Parkinson, who actually coined the term Parkinson's disease in his essay of shaking palsy, along with cardinal stiffness, tremor, and rigidity. He also described a range of symptoms, what actually the patient had described: fatigue and pain, dysautonomia, delusions, hallucinations, and sleep functions. 200 years later, if we come back now, 200 years ago, it's James Parkinson, and now 200 years after, it's Professor Ray Chowdhury. I'm proud to say that I'm, I did my doctorate, I worked with him, he's my colleague, and he described, is the Parkinson's, as James Parkinson said, is it a disease? Is just a disease of a dopamine, or is it anything else, other? And we propose that not only dopamine, the other neurotransmitters like serotonin, acetylcholine, norepinephrine plays a vital role in pathophysiology of Parkinson's disease. If you look at, ladies and gentlemen, if you look at this, we actually, in collaboration with Imperial College London, we looked into different circuits in Parkinson's patient's brain. We can see that here, it's not only dopamine, but also there are different chemicals in the brain, different neurotransmitters in the brain, or predates before the stiffness, rigidity. You can clearly see patients with problems with cholinergic, choline neurotransmitter. They have problems with cognitive failure. Patients like Mr. H, who described fatigue and pain. He has problems with serotonin. It's other patients falls. You can see patients with dysautonomia where they have tendency to fall. So that's associated with non-adrenaline. So if you just address dopamine, it's not giving a quality of life for your patients. So motor Parkinson's based on dopamine, we all know it's still a traditional scoring of if it has one side symptoms, it's stage 1, and both sides stage 2. If you have a spine involvement, it's stage 3, then to a wheelchair bound. But that motor Parkinson's, which you see from the patients with the stiffness, tremor, and slowing is just tip of the iceberg. The hidden face is actually the non-motor symptoms. I would like to share with you, ladies and gentlemen, this tool, the PD non-motor symptom questionnaire. I have to say that I pride myself to work as a research fellow when doing my degree, led by Professor Bashar at King's College Hospital. Now it's being used in 56 countries and translated in 56 languages. Now it's become a vital tool, like any neurologist, like a Parkinson's specialist, like we keep a tendon hammer, we have to use PD non-motor questionnaire in their toolkit. This is the one which validates all the important hidden non-motor symptoms. And also, first time in history of movement disorders, first time in history of Parkinson's, a textbook with 2 volumes that holds 56 chapters and covering each domain of non-motor domain. Again, it's a great honor for me to be part of Professor Chowdhury's team, to be a jewel in this crown. So what is quality of life? For a patient perspective, it's a perception and evaluation by patients themselves. It's not what we think, it's what we address, what the patient needs. Why is it important? Like chronic diseases like Parkinson's, improving patients' quality of life is the objective of caring. It cannot be obtained by simple neurological examination. You need to have a validated tools. Unless you ask the patient, they won't give you an answer because of social stigma. In a lot of Asian patients and Middle East patients, about a lot of patients have problems with sexuality. They can't actually tell to a clinician unless you give them a tool like non-motor symptom questionnaire so that they can tick each symptom. So that's the way we need to assess the needs of the patient, focusing on aspects which are interest to the patient. It is not equivalent to clinical examination. So this again, one of the King's study we looked at, I think Prof. Christian covered. I don't want to go in detail, but I just want to make it very simple, one line. This is again asked to one of the King's study, which we did 265 patients. It's a we gave them the questions, we asked them, please mark your first 3 symptoms. If you look at pain, even in a young onset Parkinson's, pain has been reported as number 4 symptom. When coming back as the disease progress, you can clearly see no one is the tremor is not on the top 5. Mainly the mood and fatigue, drooling and sleep, patients are worried about. So, when to start the treatment? If we start the treatment at the beginning of the disease, as soon as we diagnose it, or it's better to delay the treatment, which affects the quality of life. At King's, it's very clear that although we are a tertiary referral center, already seen by other consultants, other neurologists, as soon as we diagnose this, we start the treatment. And this PD Life study, it's a multi-centered observational study done by us, led by, again, Ray and our group. If you look at here, the green arm here, patients not treated, untreated. If you look at the orange arm, the patients treated. If I draw your attention, ladies and gentlemen, if you see, still at 18 months, that green arm group are still not untreated. Look at the results. Treatment naive Parkinson's patients, in other words, patients who are not treated, who are not started on any treatment, have a significantly worsening of quality of life when compared to patients treated with the Parkinson's medication. Again, if you break down those non-motor domains, stiffness, mobility, activities of daily living, emotion, social stigma, cognition, communication, bodily discomfort, pain, etc., etc. If you can, these are the 3 arrows, the colors you can see. That's the baseline, and the first follow-up and the second follow-up in 18 months. You can clearly see patients who are treated when compared to untreated patients have a better quality of life scores when compared to untreated patients. So, coming back to overall quality of life summary index. If you look at here, clearly it's very evidence-based that treated arm, when compared to untreated arm, has a significant improvement in their quality of life. So ladies and gentlemen, for clinicians, for family physicians, for doctors, GPs, as soon as you think the patient has Parkinson's signs or showing the Parkinson's signs, either refer to a Parkinson's specialist or a Parkinson's doctor. Don't delay, start today. And coming back to once, I don't want to go in deep depth because Professor Christian covered in detail, but I want to say managing advanced Parkinson's is a complex affair. Not everyone can understand and treat the advanced Parkinson's patients. As you can see, when they sail to the advanced stage, they have fluctuation of non-motor symptoms, fluctuation of pain, fatigue, sexual dysfunction, drooling, whatnot, all will be, it comes with the package as the patient sail through the advanced stage, and they'll be on cocktail of medications. I always love to show this prescription while one of my patients, if you can clearly see how many tablets he's on, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, total 19 tablets. Plus, couple for, if you're an Asian patient or a Middle East patient, you'll be on couple for your blood pressure, couple for your diabetes, couple for your cholesterol. I'm sure another 10 will be in the shopping cart, 19 for Parkinson's, 10 for systemic diseases. So what happens as the patient progresses in Parkinson's, they have delayed gastric emptying, the bowel movements will be compromised, and they get medication overload and intestinal obstruction, aspiration pneumonia. The main cause of mortality in patients with Parkinson's is aspiration pneumonia. 90% of patients die with Parkinson's, not because of the condition, it's because of aspiration pneumonia. I just want to show you for all the patients, I know I can see now it's over 270, 300 patients, carers, what is a half state, what is side effects of the medication? That's been asked by many patients. If you look at the patient here, slow tremor, this is what we call as the off state, when the treatment is not good, when the treatment is not, when the brain is not getting the proper medication. The other side here, the one which is called hyperkinetic state, where the treatment is side effects of the oral medication. If you give 19 tablets, that will become hyperkinetic. So I would say new kids on the block and device-aided therapies, we have a lot of evidence-based now of comparing each and every device-aided therapy. Now we have apomorphine pen and we have apomorphine pump, intrajejunal levodopa infusion, and of course, traditional, old, conventional deep brain surgeries. And also some new therapies, you can see inhalational levodopa, gel, and we have all in a pipeline, intranasal rotigotine patch as well. So this is a recent real-life study, multi-centered observational study by Dafsari et al. I just want to draw your attention, ladies and gentlemen, when compared to deep brain surgery, infusional therapies, the quality of life scores are much better in either in apomorphine arm or intrajejunal levodopa infusion arm. So take-home message is to get the best way to maintain quality of life of our patients is empowering patients with choices. We should give the patients, explain to them evidence-based pros and cons and what is best. Let them decide. And to conclude, as I said, you can see Parkinson's is a complex combination of motor and non-motor symptoms. The concept, quality of life, bridges between the disconnect, top-down clinician and real-life patient-based concepts. Timing of treatment is very important, can enable maximization of quality of life. Emerging evidence has shown that infusion therapies could be considered an option before considering conventional surgery, and empowering the patients with the right choice is critical. So I just want to thank for your attention. I just want to thank you, our director and our team, Chowdhury at King's, and we have excellent team at King's Dubai, led by Dr. Vittorio, our neurology team, and advanced therapy programs at King's will be directly supervised by Professor Ray Chowdhury and myself. And so you can have a lovely advanced Parkinson's therapy team there. So just thank you very much.
Thank you very much, Vinod, for this excellent presentation, highlighting that Parkinson's disease is not only motor but non-motor and functional, and certainly Parkinson's patients needs continuous treatment and medication without fail, or else it may result to rapid worsening, and there is a clear room for tailoring the treatment to patients' needs, especially for advanced Parkinson's disease. Thank you so much, Vinod.
Thank you.
Dr. Vittorio, if I may interrupt.
Please do.
We would request Dr. Abu Bakr to translate the summary of this in Arabic for those who understand the language better.
Thank you guys for allowing me to translate in Arabic. Thank you Dr. Christian and Dr. Vinod.
Thank you Dr. Abu Bakr.
أعزائي المرضى وأهالي المرضى، حاب أشرح لكم باللغة العربية في ما قاله الدكتورين دكتور كريستيان ودكتور فينود. بس عشان نلخص ما هو مرض الباركنسون. مرض الباركنسون يتلخص في 3 أعراض أو 4 أعراض كبيرة: تصلب العضلات، الرعشة، أو عدم التوازن أثناء الحركة. الدكتور كريستيان في المحاضرة لخص بشكل جيد ما هو مرض التصلب أو مرض الباركنسون المتقدم. يعني متى يكون المرض متقدم، يعني متى يكون مرض يعني صعب علاجه. لخصها في 3 حالات كبيرة. الحالة الأولى صعوبة الحركة. ما هو معنى صعوبة الحركة؟ صعوبة الحركة إذا في تصلب أو عدم حركة لمدة 2 ساعات في خلال اليوم، أو في حركات لا إرادية لمدة 1 ساعة على الأقل في اليوم، أو المريض يحتاج الدواء المعروف الليفودوبا أو السينمات أكثر من 5 حبات في اليوم، مع ذلك ما يتحسن أعراض المريض، ما تتحسن أعراض المريض. هذه حالة من الحالات. الحالة الثانية الأعراض الغير حركية، الغير معروفة بالنسبة لأهالي المرضى بس معروفة للمريض، كالقلق، عدم النوم، مشكلة الذاكرة، مشكلة البول والبراز. هاي الأعراض إذا بدأت تبرز في المريض يعني نقدر نقول إن المرض بدأ يتقدم في الحالة. الصعوبة أو مساعدة، المريض يحتاج لمساعدة خارجية أساس يعمل الأعمال الطبيعية اليومية. في هذه الحالة ممكن نقول المريض هذا بدأ يجي مرض الباركنسون المتقدم. فتلخيصه ب3 حالات: صعوبة الحركة، الأعراض الغير حركية الغير معروفة، والمريض يحتاج لعناية من الأشخاص الثانيين لمساعدته في الحركة أو في المشي أو في العناية ككل. هذا كان ملخص دكتور كريستيان. أما الدكتور بينود فلخص وشو هي الأعراض المخفية اللي نشوفها في مرض الباركنسون، شو الأعراض اللي نحن ما نداركها، المريض يعرفها نفسه، فلازم نبرز هالأشياء كالآلام. يعني في مرضى كثار فيهم آلام يتحولون لعدة أطباء، يطلع في النهاية مرض الباركنسون هو مسبب الرئيسي للآلام عنده. كذلك ضعف الذاكرة قد تكون عرض من أعراض الغير حركية لمرض الباركنسون. الضعف الجنسي الأعراض نعتبر من الأعراض الخفية وفي مجتمعنا نستحي نتكلم عنها. الأعراض الهضمية كالإمساك، الغازات، صعوبة البلع في بعض الأحيان ممكن يؤدي لالتهابات في الرئة، وهذه ممكن إبرازها بشكل واضح للمريض والتطرق لها. الخمول بالذات والصداع، عدم التوازن، التخيلات أو التهيؤات كثيرة للمريض، القلق وعدم النوم أو النايت ميرز أو الكوابيس اللي تصير أثناء النوم. هاي أعراض غير حركية ما نتطرق لها في الحالات العادية، بس لازم نبرزها نسأل عنها للمريض عشان نركز عليه ونعالجه. يعني مو بكل شيء الملخص، مو بكل شيء باركنسون معناته صعوبة الحركة. في أعراض ثانية لازم نتطرق لها ونبرزها ونعالجها بأتم الحالات. شكرا جزيلا. Thank you very much for allowing me to translate. Go ahead for the next session, please.
Thank you very much, Dr. Abu Bakr, for being with us. It's an honor to have you as part of this forum. Now, let's proceed with our next speaker, Dr. Anna Rotzman. Anna is a specialist nurse consultant from the Department of Neurology and Faculty of Health Science Medical University of Gdansk in Poland. She has been, was, and is certainly invited to present her findings, lectures, and workshops in many meetings. I guess she has been in Dubai a couple of years ago for a meeting which was an amazing one. And she is a specialist in implementation of care and aftercare in patients treated with duodopa, which is the continuous intestinal levodopa infusion. So I'll leave the audience to Anna. She will talk about the do's and don'ts of levodopa infusion therapy. Anna?
Hello, everybody. I'm very happy to join the forum. I would like to say my great thanks to the Friends of Parkinson's United Emirates, Government of Dubai, Community Development Authority, Dubai, Emirates Genetic Association, and Emirates Neurology Society, King's College, Dubai. And my special thanks to Chairman and Her Excellency to launch the forum, and I'm really very excited and happy that you want to get to know my experience and knowledge on Parkinson's disease and what we are doing as well in Poland. Can I ask if you can see my slides? Is it okay?
Yes, we
Yes,
can.
we can.
Okay.
Yes, we can.
So to start, how it is in the literature and as well from my work experience, I know that the collaboration, good collaboration is essential to start a good center for infusion therapies. As Parkinson's disease has complex nature, it's really necessary that many professional specialists are cooperating and this cooperation is regular and they know each other properly. Such a key points on and for the team are to build your team, to meet, to talk, to decide about the responsibilities and the treatment plan, to share the duties, to settle the procedures with respect to the individual needs of the patients, to implement the actions on time, to coordinate all the process and to fulfill all the needs, actions in proper time and good environment for the patients. So it's like when we start with this and we have a good team, then it's a very good way to make the job properly. And as such a very basic team, who we need there. Definitely in the center is the patient and his caregiver, movement disorder specialist, PD nurse, gastroenterologist skilled in endoscopic procedures, and neuropsychologist. But this is like a very, very basic, and for sure it's not enough to make the proper treatment plan. The essential and ideally required team would consist as well of physiotherapist, dietitian, primary health care, and speech therapists. What's more, except such a cooperation in the team, we should definitely cooperate in the country and as well internationally. Like in Poland, well, I have experience of more than 17 years in movement disorders, but duodopa was introduced in not so long time ago. It was 2017, so now it's 3 years. But till now we have 8 centers. The main one and leading is in Gdańsk, where I work. And what we do is definitely we meet regularly. We have regular sessions. There's very good cooperation between PD nurses. And I think it's something what allows us to keep up to date and as well avoid some unwanted issues. To go further, yes, going further with the disease, when we implement the device-aided therapies and infusion therapies, after the diagnosis, when the treatment starts, patients have their honeymoon period. They are really satisfied with the symptoms relief. But unfortunately, after some years of the disease course, the symptoms are becoming more and more difficult. And then it's the time to make the decision about a different therapy than oral. At the moment, as you heard from other speakers, we have many possibilities for the patients. Infusion therapies, patches, deep brain stimulation. But it's really important to make the decision. At the moment, we have a simple screening tool. Well, in 2018, the Delphi Consensus Study published such recommendations for more simple screening, and it's like just 5 times oral levodopa, 2 hours of off time, and 1 hour of troublesome dyskinesia. So it can be such a helpful tool for general neurologists to send such a patient to movement disorder center for more deeper screening of the patient to decide the best therapy for him. Why time is so important? I think we shouldn't wait too long, because what will happen if we wait too long? The patient's condition will become worse, his physical condition, he will be weaker, his muscle, his strength, reduction in overall physical condition, and patient's nutritional status will become worsened. And it's not good to bring patients to this stage. Yes, as I told before, we have mainly these 3 options for advanced Parkinson's disease. What is as well very important that we should speak with the patient and caregiver about their expectations from the treatment. It's really important to exactly choose the right treatment for the right patient. He's according to his symptoms and as well according to his life, what he still wants to achieve, and what are his plans for the future. Definitely we should know that the patient should be realistic about the treatment. It's not like a miracle, but it can help a lot. And beyond the treatment, the most important for the patients are to keep him motivated to still fight for his physical condition, for his diet, and to have proper sleep. Because those 3 things will strongly support the pharmacological treatment. What are the main goals for PD treatment? In the initial phase, we just want to control the movement difficulties, to prevent of motor complications, prevent additional symptoms, and modify the disease course to make it slower and to increase the quality of life. And in advanced phase, we would like to maintain symptoms control and avoid of complications. When we choose duodopa as the treatment for the patient, there are like 4 main steps in before the treatment and after. Like the first step would be pre-qualification during the consultation or in neurology center or later on in movement disorder center. Later, the qualification in neurology ward where we do all the necessary tests. And yes, in the pre-qualification, during the consultations, what is, I think, as well very important to introduce the therapies to other physicians, not only neurologists, but as well GPs, because we have many Parkinson's disease patients who don't receive patients. When we start nasojejunal tube placement, it's a little bit unpleasant for the patient, but it's not painful, and usually patients don't have much complaints about it. We have three possibilities to place the NJ tube to the patient. One, I think the most friendly for the patient is the passive possibility, and we are using this one in Poland. The other two are using endoscope, so they might be more unpleasant for the patient, but they are more fast. But on the other hand, I can say from my experience that the passive way is as well not much longer for the patient. And definitely it's much more comfortable and not so painful or unpleasant. After the NJ tube placement, what we do, we ask the patient to eat such a food like bananas or potatoes, just to allow the tube to go through to the intestine more easily. As well, then we prepare the duodopa pump. We make the settings individually for the patient as he should get the doses according to the medication he was receiving previously. We're doing the morning dose, which is given in more fast way. Then we're making the extra dose and continuous dose. After this 1 or 2 days on the nasojejunal tube, when we are seeing that patient is satisfied, the symptoms are lower, and he's decided to have the PEG-J, then we prepare the patient according to our hospital standardized procedures. Usually we're putting IV to the hand, which will be more suitable according to the room where we make the procedure. We're giving antibiotics to the patient. He should be fasting for 12 hours before. And we are making special hygiene procedures before, like oral hygiene is very important, oral mouthwash, and showering full body with surgical soap. What is as well very important, how to choose the best place for PEG-J insertion. And this is something what we should talk with and show to the endoscopist before the procedure. It's the abdominal wall transimulation for sure, but we should avoid the skin folds and try to put it not close to the ribs, because these are two reasons that later on may lead to discontinuation of the treatment. And as we know, we starting the duodopa treatment, we're planning to continue it for many years. So it's really important to choose the place properly, and not only transillumination can be the only good reason to place the PEG. What is very important after the care about the PEG? After the PEG insertion, on the first day, patient is fasting. The minimum fasting is 8 hours. It's important to support patient with hydration infusions and painkillers. Usually, most of the patients feel the pain in the place where we place the PEG. On the second day, already the patient can eat easily digestible diet. And on the third day, he can eat his normal regular diet. What we do on that time, we are continuing the titration and we continue the patient and the family education. What we do already on that stage with the carers, it's like what I do with the patient at hospital. Before, I was educating them on the procedures, and already on this stage, I ask them to make all the procedures by themselves with me, that later on, when they will go home, they will feel comfortable that they are able to do everything by themselves, and they will be independent with it. Of course, always they have the knowledge that they have my telephone number, they can contact me, and on any time I will support them. Usually around 2 weeks after the PEG insertion, patient can take a normal bath without dressing. About stomach care, such a few important details. We should keep the PEG under moderate tension for 24 to 72 hours after the insertion. It's important not to cause bleeding, and it as well reducing the risk of peritonitis and pneumoperitoneum. We should change the dressing every day, just once daily, clean it with tap water and keep it dry. And we should move the gastric bag in and out without turning around. What is sometimes challenging, that patients and the caregivers are thinking that when it was such a big procedure on their body and they have hole in the belly, so they should use a lot of antiseptics and special liquids to keep the stomach care properly. But it's really very important to convince them that tap water and keeping it dry is the best care for it. Swimming and bathing. I'm from the seaside, and many of my patients are as well from the area. And they like to bath. And I have to say that having a duodopa and PEG-J is not something that will not allow them to continue these pleasures of their life. Here you can see pictures of my patients swimming in the swimming pool, but I know many of them are using bathing in the sea and as well bathing in the lakes. So during the summertime, they can have their before and still such a happy activities as they liked. Education. What are the main things about the pump and as well about the stoma? About the pump, because as later on I will show you research papers, it's like the most problematic things are concerned with the pump. We should advise patients to have the batteries at home because they have to replace them every 7 to 10 days. We should tell them about high pressure alarm. And usually the most often reason of the high pressure alarm is the red flag that patients forget to take it off. I prepared many educational materials for my patients. Here is some example of instruction for everyday routine for the patient, because when they go home, accept the knowledge they got from me in the hospital. I would like them to have something on paper or some videos which can support them with everyday routine. But of course, after probably a few days, they already don't need those papers. Here are some examples of these materials. And what is important to educate about some parts of the treatment in the proper time. We're not saying fully everything totally at the beginning, and we are not doing exercise with the patient about the caring for the patient at the beginning. We are just doing it step by step as the treatment is going on. But of course, what is very important, we should tell to the patient at the beginning what he can expect from this and what will be the challenges with having a PEG-J. LCIG aftercare complications and education on that stage. Duodopa is on the market around 15 years, and already we have really a lot of studies about safety and adverse events. The Gloria study was such a big study where Professor Antonino and with his fellows showed that definitely ACIG leads to sustained improvement in motor fluctuations and is a very good treatment. But of course, there are some troubles that patients can have during the treatment, but usually most of them are connected with the device or with the stoma, and they are concerning most of the things we can easily manage, and they are not very serious. In another study of UD, they found out that the majority of complications were related to PEG-J. It's like granulation tissue, skin redness, infections, and as well sometimes patients lose the weight. Some studies are showing even that 1/4 of the patients are losing weight. So that's why what I was saying before, that diet is something which should be definitely included in the education for the patient. Going further with the stomach care, what can happen with PEGs inside and outside? We can have loops, we can have folds or obstructions or nudes. But with all of these things, we can easily manage. And what is very important as well, that with most of those things, nurses can easily manage, and there's no need of involving the endoscopist again. Even if we have loops and we have to take out the tube from the patients, or sometimes even it happens that accidentally the tube is disconnected and will go the natural way out from the patient, the nurses are able to put the intestine tube by themselves, and there's no need of any extra and difficult procedures to be done on the patients. What you can see here on the pictures, these are pictures of some of the complications that happened in my patients, but all of them were easily treated, and it's really nothing to be scared of. The team education, what would be the main points? It's very important that the Duodopa team will know deeply about the PEG-J components and its functions. That if something happens, they can easily help to the patients. Most of the complications might be avoided and properly managed. And patients should be provided with individualized care plan. Diet and physical activity are crucial to support effectiveness of any treatment. So this is something like the main basic things should be always covered in the treatment. And what are the good and bad sides of duodopa infusion? On the positive side, we have that duodopa provides a continuous infusion and of the drug and the therapy into the small intestine. Thanks to this, we can relieve the patient from the symptoms. We will reduce the fluctuations more effectively than we may by oral medications. We will improve the daily on and off stage. The degree of improvement of times reveals that seems very similar to deep brain stimulation, and duodopa reduces the amount of pills that patients is taking. Like Dr. Vinod was showing his prescriptions and talking about how many pills the patients are taking, and it's really troublesome for them, even in the case of eating. Because as we know, patients should have a time before and after the medication to make it work. And what are the negative and more difficult sides of duodopa infusion? The problems with the tube and the stomach care. The cassette of the duodopa must be changed every day, but it's only once a day fixing and once a day taking off. It's not like taking 15 medications during the day. The pumps, the pumps that moves the medication and cassette is worn outside, and it's not so light. It's a little bit heavy, and I would say after wearing it for 16 or more hours, it might be heavy for the patients. We should be careful about the depression in duodopa patients, and still the abnormal movements like dyskinesia can occur during the treatment. Definitely we should look to the future for personalized and best solutions for the patients. I'm really on the side that we should always choose the best treatment for individual patient, because it's very, very different for every patient. And I would like to wish you and your patients a good choices and work in good cooperative multidisciplinary practice that will help you to achieve best goals and things for your patients, that they can be happy and live their life as good as possible. Thank you very much.
Thank you very much, Anna. Certainly highlighting how important is a multidisciplinary team approach to patients, especially for patients with advanced Parkinson's disease. Thank you very much for this presentation. Now, I would like to introduce a man who probably needs no introduction. Professor Ray Choudhury is a consultant neurologist and professor in neurology movement disorders at King's College Hospital in London, and medical director of the National Parkinson's Foundation International Center of Excellence at King's College. He has got many feathers on his cap, many membership of associations, and is the chairman of the Movement Disorders Non-Motor Study Group. He's author of 300-400 papers or more, co-editor of books on Parkinson's disease, and is a recipient of many awards, including an outstanding research for contribution in the field of non-motor Parkinson's disease. In this difficult time for us all, COVID-19, it wouldn't be more appropriate than now to enlighten us about COVID-19 Parkinsonism and advanced therapies. It's a pleasure to have here Professor Ray, and an honor for me for Professor Ray to be part of the neurology team here in King's College Hospital, London, Dubai. To you, Ray.
Thank you very much. So firstly, I would like to thank Dr. Vittoria for chairing this session and having me, and also to various other people, particularly Dr. Gauri Ramanathan, and of course, Her Excellency, Dr. Mariam. I'd also like to thank Dr. Suhail and Dr. Almadani for negotiating and coordinating this session so well, all the other faculties, and Dr. Vinod Mehta, and for all of you for staying up. Must be quite late, so I try to be brief and to the point as much as I can. So I start sharing my screen, and I think this is my slide. So I just thought I would give you a very quick update on what we know about viruses and Parkinson's, and bring it to the level of levodopa infusion therapy, and talk a little bit about some of the new things that we have, and try and do it relatively quickly, because I'm sure everybody would like to finish and go home. So we are in the middle of a pandemic, as you heard from Dr. Vittorio, and we've had many pandemics. It's not new, but this one is particularly different in that we don't really know much about this virus. You see that we've had previously the SARS virus, the MERS, which is the Middle East respiratory symptom related, but going back to the historical ages of having plague and so on as well. So pandemics are not new, but of course the impacts can be quite devastating. And we also now know, and coming straight to the point, that this virus appears to have neurological manifestation as well. So this was one of the first papers that came out from Wuhan, where the origin of the virus was that a range of neurological symptoms can occur, and as shown here, these can range from dizziness to headaches to impaired consciousness, ataxia, but perhaps what is more relevant for us is the impairment of smell or hyposmia and and impairment of taste, so ageusia. These two are relevant because they are relevant to Parkinson's. And if we looked at another paper that came out more recently, this is an interesting survey that showed that if you looked at the psychological and mental concerns, you can see that this Ipsos Mori, the figure that will be to your left, shows that there's quite considerable degree of problems with isolation and particularly mental illnesses related to the COVID-19 issue. And then when you to your right is a cross-sectional survey about healthcare workers, and you can see that there is distress, there is depression, there is anxiety, as well as insomnia. This is happening amongst healthcare workers like us who are dealing with the issues of COVID-19 in the hospital and also in the community. So the impact of this virus is quite wide. Why this is so, we don't know. There is an evidence, or there is some suggestion from animal models that the virus can directly, through a tropic mechanism, go into the basal ganglia where they can replicate and cause neuronal lysis. That's a possibility. There are indirect effects through the T cell, through inflammatory response, loss of vascular integrity, hypoxic brain injury, all of these. And we've just recently published this. This is just due to come out, this paper. So these indirect pathways can also be relevant to neurological complications. It seems the evidence at the moment is this virus might attack our neurological system, both in the periphery and in the central nervous system, through an indirect mechanism rather than a direct mechanism, which is a good news, really, for any of us who've had COVID-19 infection or will have it, because some of us will probably get the infection in the months. Now, this is a recent editorial article that came out in the Movement Disorders Journal from a group of experts, the impact of COVID-19 and possibility on Parkinson's disease. And the two questions are raised. One, and this is relevant to us very much, that is the Parkinson population, or are the Parkinson population particularly vulnerable during this pandemic? And if so, can we bring in a specific role of telemedicine to reach out for people with COVID-19 or those who might be susceptible to COVID-19 during this period? So those were two specific issues that were raised in this particular article. And they also mention that the physician must ensure the maintenance of adequate doses of levodopa. So it's very important to remember that, and I'll come to this later, that if you have a Parkinson person who gets COVID-19 or has a respiratory tract infection and they come into hospital, it's critically important to keep up their levodopa equivalent doses, because the evidence suggests that the infection can increase your requirement for LED. So that's another sort of anecdotal experience that has been so far seen. Now I'll show you a video. I don't know whether you'll be able to hear this, because I wonder if you can hear that. So if you didn't hear it, that's a famous actor, Billy Crystal. And Billy Crystal there is talking about Robin Williams. Robin Williams, another very famous actor, who died, sadly, committed suicide a few years back after being diagnosed with Parkinson's. Now we know that that was probably DLB. And what he says there, for the first time, Robin Williams came and spoke to Billy Crystal, who was his friend, that he was really scared. And when he was asked why, he said, I've just been diagnosed with Parkinson's. So Parkinson's diagnosis itself can be very traumatic for our people with Parkinson's. And on top of that, when there's a viral threat, those anxieties can be particularly heightened. And here are some reasons. We know that in 40% of our patients, there might be pre-existing dyspnea. Now, this might be related to the rigidity of the respiratory muscle, or could be related to diminished drive from the brainstem respiratory centers. We also know that 65% of people who get COVID-19 may have olfactory deficit hyposmia. And these patients can be misdiagnosed because there may not be any other symptoms. So they might be carrying COVID-19, but they might be hyposmic. And we also know hyposmia, that it is a prodromal feature in Parkinson's. So there is a link. Whether or not hyposmia of COVID can lead on to future development of Parkinson's, we simply don't know at this moment in time. And then we know the lockdown itself, including lack of exercise, can worsen the anxiety that you already heard in somebody like Robin Williams when a diagnosis of Parkinson's was given. So these are very different strands of the different threats that might occur for our people with Parkinson's. And this is not new. In 1992, there was a very nice paper from Stan Farnes group in New York, and they showed that even in Parkinson patients, there was evidence of antibodies to serum coronavirus in the spinal fluid. And this particular virus had a neurotrophic effect for substantia nigra. And substantia nigra, as you know, is the key area where we have dopamine cell loss in Parkinson's. So there is a link. But of course, I must emphasize that this is coronavirus and not SARS-CoV-2 that we're dealing with now. So, and lots of research is underway to see if there is a potential link or not. There is another very interesting area, and I know this basic science is not an ideal thing to discuss at this moment, but it's worth remembering that if you have this SARS-CoV virus here in green and dark green, and you see this light green area, which is the spike protein on the virus, and here you have the angiotensin converting enzyme 2 receptor, ACE2 receptor. So you see the spike protein fitting in very snugly with the ACE2 receptors. So what it's telling us, wherever in our body we have the ACE2 receptors, this virus is going to go and stick to that. And that's not new to SARS-CoV-2. If we look at the 3 other main viruses in the scene, so originally was the SARS virus, which came to us in the 2002, which is C. Then you have the MERS virus, which is the Middle East respiratory virus, which is similar to SARS-CoV-2, which came after this initial SARS. And then here you have in B is SARS-CoV-2, which is our current coronavirus, particularly MERS, which is the Middle East virus, the respiratory virus, and SARS-CoV-2 share a very similar spike protein. So the idea is that if you have MERS-CoV patients, and if you followed them up, their long-term sequels or sequelae might be similar to what we'll find in some of the heavily infected coronavirus patients in future. Whether this is going to be true or not, we don't know, but certainly the molecular elements of this virus suggest that that might indeed be the case. And this is another very interesting review which has come out just a few months back. Here you have a diagram of the brain, and the different colors tells you the different parts of the brain. Of course, the neurons, the microglia, the astrocytes, the oligodendrocytes, and you can see that all of these areas carry to some extent ACE2 expression, which is the angiotensin converting 2 enzyme. And of course, in theory, if this virus can get into the brain, then it can bind to all these places and then thereby bring in a downstream change. What could be these downstream changes? Well, the downstream changes could be of various type, and this is a very recent review that I suggested, we've just published actually. You have the olfactory nerve here, you have the lingual nerve. So through the peripheral part of the nose and the mouth, the virus can get in. It can get in through then conduct through the nervous system, through either the cribriform plate into the olfactory bulb, or from the lingual nerve into the brainstem. And from there, it's a proposal that it can get into the cellular structures and bring on 4 mechanisms. One is autophagy, so it can hasten delay the normal autophagy process that clears up our waste products in the neurons. It can bring in endoplasmic reticular stress. It can reduce proteostasis, and it can bring in mitochondrial dysfunction. All of these are not good phenomena and can lead to misfolding and aggregation of proteins. And we know alpha-synuclein aggregation is one of the key mechanisms for the development of Parkinson's. Whether this might happen or not, nobody knows, but there are theoretical considerations, particularly as hyposmia and ageusia are so common in SARS-CoV-2 patients. Any other example, any other evidence? Well, this is some MRI appearances that has been published. You can see quite diffuse abnormalities of white matter changes here, but this also involves some of the basal ganglia structures in the pallidum as well as in the striatal area. And in fact, this is again another case series from our own cases here at King's. This was collected by Valentina and Lucia, and you can see in both these cases there is evidence of basal ganglia and pallidum changes in COVID-19 cases. Whether this is a direct effect or a secondary effect of systemic vascular problems is unclear, but there is clearly evidence that basal ganglia can be affected. The other thing is the altered sense of smell, particularly taste, and this is another recent paper suggesting that if you have SARS-CoV-2 infection, most people recover their sense of smell, but if the sense of smell deficiency persists, then that's the particular group that we need to probably follow up in the long term to see whether or not there might be any evidence of any neurological or neurodegenerative disorder in the long run. But again, at this moment in time, we really don't know the data much. And here again, there is some example that it can, the virus getting in through the olfactory epithelium can then go through the transsynaptic barrier, and this can cause damage within the neural cells. So these are all theoretical considerations for these SARS-CoV-2 patients, and particularly if such a patient happens to also have Parkinson's. Now, the other important thing to remember is with the olfactory bulb comes the imaging evidence. This is here, you can see the 2 olfactory, bulbs are lighting up, and here is the actual enhancement seen on the MRI. And after a while, this is after 28 days, you see that this has largely disappeared and the enhancement is much reduced. So the good thing is it appears to be a reversible phenomenon in majority of subjects. Now, this is the first world first real life case series that again we published, and this was data from our King's cases and a few cases collected from Italy from Angela Antonini's group. And what we reported was that older patients, particularly those over the age of 70, 75, and those on advanced therapies should be recognized as a high-risk group. And this is relevant to all of us, and particularly those taking levodopa infusion therapy. We also reported anxiety, fatigue, cognitive impairment, and psychosis can get worse, and in fact also dyskinesias. And this is important to note, because if you are an acute clinician, acute care clinician, and if you have a patient with Parkinson's infected with COVID-19 on advanced therapies come into the hospital, there needs to be awareness of these issues when you activate your new pathways of care. And staying on with this, there's been two further papers. This is from Alfonso Fasano and others from Italy, and he looked at, or they looked at COVID-19 patients with Parkinson's in the Lombardy area, and they actually found that the risk, morbidity, and mortality in mild to moderate Parkinson's is the same as general population. So there is no need for concern unless you have advanced Parkinson's. And they also suggested that there might be a protective role of vitamin D, although this has not been certainly suggested or confirmed in any large-scale studies. But it seems like if you have a patient with COVID-19 and Parkinson's, giving vitamin D may not be a bad idea. And in this paper, this is from Roberto Cilia, again from Italy, but this was more a community-based case-controlled study. Their data actually were very similar to ours. They found that in their Parkinson patients, there were more problems with dyspnea, with headaches, with fatigue, with anxiety, and skeletal muscle pain was particularly aggravated. This is very relevant that the pain management in these patients need to have a specific focus, because pain, for reasons not entirely clear, seems to get worse in these patients. And we need to be aware of that when we think about managing these patients. So if we summarize these two papers, one from the Lombardy, one the case community, both have suggested that advanced Parkinson patients, just like we did in our original paper, can have a worse outcome. You have to be careful about these patients' non-motor problems, particularly anxiety, depression, as well as pain, and also dyskinesias in particular get worse, and the outcome seems to be worse if they're on advanced therapy, and that's either DBS, levodopa infusion. We don't really have data on this with apomorphine as yet. The other thing about COVID-19 is that it affects different racial groups differently, and this might be of relevance. I don't know what the data is in UAE and particularly in Dubai. This is Public Health England report about the disparities in the risk and outcomes that the government has been looking at. If you look at, and I don't know how well it projects, but very quickly, if you see Black and Black British and Asian British, these two groups, if you take out any other ethnic groups, have the most risk of developing the COVID-19 or getting COVID-19 infection. And in fact, if you look at ourselves, and in the UK we call ourselves BAME, which is Black and minority ethnic communities. So Asian British doctors, nurses, midwives probably have the highest risk of developing COVID-19. So this might again be, the cause of this is unclear. There could be genetic factor, there could be comorbidity related issues. We know, for instance, cardiovascular disease, hypertension and diabetes are overrepresented in the BAME group, and they seem to do worse. So if you're BAME, if you're hypertensive, if you're diabetic, if you're obese, and you get to COVID-19, bad news. And then if you are Parkinson's with these non-white ethnic group, this same observation might actually apply. And in fact, this particular survey. This is Chinese data showing that diabetes and hypertension featured mainly as the more dominant comorbidity. And this is a very recent piece of work that Anna Sarbe, is one of my fellows, who's just submitted for publication about the fact, and Anna actually had collaboration on this work, not this work, but previous work from the Middle East, from UAE and as well as Kuwait, that the Black and the Asian minority ethnic subjects appears to have a slightly different pattern of Parkinson's. We need to be aware of it. One size doesn't fit all. The clinical trials data that we all rely on is almost exclusively based on white Caucasian subjects, but we are applying that to a different ethnic group. Is it the same? Not so in my view. And this might be actually a relevant issue in relation to BAME and Parkinson's and COVID-19. So this would be a particular thing perhaps to look at in your own cohort. If patients with Parkinson's, they get COVID-19, what is the outcome in this particular group? And I believe this might be different, particularly if there is associated comorbidities such as diabetes, obesity, and hypertension. Pain, this is a very recent piece of work again with Katerina, who's one of my other fellows who has interest in pain. And she has done a telephone survey with Miriam Parry, who's our nurse specialist. And they found that if you can see this data, that prior to COVID-19 pandemic, if you look at the pain score, this is a simple telephone administered pain questionnaire, which is validated, that during the COVID-19, this increased quite significantly. So as also noted in other studies in neurological manifestation of Parkinson's, of COVID-19, pain seems to get worse. Now that might be due to a physical inactivity, that might be due to reduced physical exercise, perhaps increased muscle rigidity. We don't know really why, or might be even due to a secondary effect of worsening depression and anxiety, but it's something really we need to keep in mind. You could see here 64% reported in this particular cohort that the pain had got worse during the COVID-19 pandemic, not necessarily with the infection, but just with the lockdown. And this is coming in from a more nursing angle. This is Annette Hand, who's written this nice piece of review with myself. And Annette is a nurse consultant here. This was published in the Neuroscience Nursing Journal. Really, it gives you some practical tips. And the issue about anosmia, particularly if you have a Parkinson patient who suddenly becomes anosmic or hyposmic, think COVID, or has a shortness of breath, think COVID, because these things might happen without necessarily other symptoms and signs becoming evident. And here is the sort of an algorithm, if you will. What will you do? So we've divided this into the level of impact. So you might have Parkinson's patients on self-isolation, which is the majority. In these patients, anxiety, depression, sleep problems, particularly insomnia, lack of exercise, secondary pain might be an issue. Here, we really need telemedicine. We need regular phone contact, and we probably should try and provide online exercise type classes. Then you can have a mild to moderately affected Parkinson's patient with COVID-19. They might be young, they might be otherwise relatively healthy. Usually here, they will have a good outcome. Self-isolation is very important. The usual rules apply. If they get worse, they will need to be hospitalized. In these patients, what do we need to do? We need to reassess their levodopa requirement. If required, the dose might need to go up. We need to specifically address fatigue, anxiety, depression, and pain. We need to promote chest physiotherapy because their respiratory drive might be low. And finally, in some patients, because of hospitalization, delirium might occur, and you need to keep an eye on that. The problematic group is the Parkinson's patients with COVID-19 who might be advanced and severe. These patients will need monitoring for ventilation. In fact, in our series, 3 patients needed ventilation. And in particular, it seems those on levodopa infusion therapy might be particularly vulnerable. So you need to really keep an eye. And in these patients, you might need to increase the levodopa dosing, address the comorbidities very actively, diabetes, for instance, hypertension, for instance, and you might need to use other non-oral therapies if they're already on oral therapy. So in some cases, retigatin patch or even apomorphine infusion might be required if they're already not on a non-oral therapy. So that's a sort of a broad broad sort of roadmap, if you will, of how you might address your Parkinson's patients, the level of impact, and what management strategies you will undertake. I'll go over this one quickly because I just would like to end a little bit about sort of going into the future a little bit. What can we say? Well, I think from research purposes, I think the critically important thing is to identify those patients who have irreversible or persistent hyposmia after COVID-19. So cohort of such people really needs a long-term follow-up to see what's happening, because at this moment in time, we really don't have enough knowledge. We also need to be aware that you should have a roadmap, or you should have a little operating guideline for what you will do in severely ill patients, particularly use of liquid levodopa if required by nasogastric tube, transdermal patch. You can convert the levodopa dose, apomorphine infusion or injection. And if the patient is on levodopa infusion, it's important that it's continued, but the dose might need to go up. But in addition, as we've already said, that fatigue, anxiety, and pain needs to be addressed, impaired cough with physiotherapy. And one other thing is that some of the cough remedies that people buy over the counter might interact with selagiline or asagiline or sulfonamide group of drugs, and that's something we need to keep in mind. What about other ways? Well, vaccines. And you would know that 2 days back, Lancet published the Oxford vaccines trial, which is the sort of an adenovirus which is effective in chimpanzees. That's been now trialed in a very rapidly, and we at St. Thomas's took part in this trial, not at King's here on this side, but part of KHP. And this showed that there is immunogenicity, and it can provide an immune reaction and a T-cell response. And coming on to us will be several vaccine studies. The one that's coming up is the Janssen one and the Moderna one. And it's important to note that Moderna will look at particularly vulnerable populations, so BAME, older subjects, those with comorbidity, because the Oxford trial, the initial trial, has really looked at healthy subjects. But what we really need to find a vaccine that works in older susceptible population. And this again, if it happens, we will be able to transpose and translate these findings to a Parkinson population. What are the new kids in the block? And I'll end with that. You've already heard from Anna and from Vinod that about levodopa infusion therapy, in my view, probably remains one of the critically defining treatment that we have with us at the moment. There are enough data to suggest that it's a very, very good treatment, not just for motor, but also for non-motor functions. There are several registries, the EuroENV, Gloria, DuoGlobe, Insights. They've all suggested that since the original paper by Honig et al. In 2009, which showed for the first time that this is the therapy that really, really helps a whole range of non-motor problems in Parkinson's. But the new kids in the block are Lasijon, which might come our way. Lasijon is the same, the infusion, but this one contains entacapone with it, so it lasts longer. And you'll see that the pump is a lot smaller, so patients will probably like it. The weight of a standard Lasijon pump, the size is compared to the duodopa pump, and you can see that it's substantially smaller, and it also can give an adjustable rate. And at this moment in time, we will see how Lasijon works. I'm not saying duodopa will not be used, but I think both drugs will be available for people to try. It might be good for some, may not be good for the others. What are the others? So there is AbbVie is now in clinical trial using the M15741, which is a subcutaneous infusion of levodopa. Actually, it's a prodrug. if this works, this is through a patch pump device. This will be sort of like levodopa apomorphine type drug, if you will. So it's basically levodopa given like apomorphine. This might have enormous future, although skin reactions remain a problem, and we are actually doing this trial as we speak. And another very exciting trial that I'm particularly excited by is the headphones. This is a non-invasive, non-pharmacological treatment. You wear a headphone and you have the headphone on for half an hour per day for a month, and the effects in one study which has been now published has been quite dramatic. Effect on non-motor symptoms specifically, and now I'm helping the US company develop a trial across the US and also King's, and therefore let's hope King's Dubai can take part in this as well, to look at this particular vestibular stimulation device. It gives you hot sensation in the ear on one side, cold on the other side, and stimulates the brainstem and produces these dramatic effects, which seems to last up to 3 months. So it looks a really, really impressive new development. And finally, we mustn't forget that we must always sing, we must always dance, whatever our moods are. And ballet is making a comeback. I'm not sure how popular ballet will be in Asia, but nevertheless, in England, we're very excited, and thus Wellcome Trust has funded us a big grant through English National Ballet. So we're going to give ballet as a teaching, as a group therapy for groups of people with Parkinson's, because it seems to have a great effect on balance. It seems to have a great effect on sleep. It seems to have a great effect on mobility, and it seems to have a very good effect also on social communication of people with Parkinson's. So not just drugs, you can have vestibular stimulation, you can have dance therapy. All of these things will be coming our way in the future. And with that, I'd like to end and thank a lot of people. All the guys have helped us put some of the slides I presented to you. This is a little of our steering group. We have our meetings, and as you can see, we also have a lot of fun. On contradiction, on the bottom, we have 2 very serious pictures of all of the distinguished guests, Dr. Mehta, Dr. Guy Chun-Fei, Dr. Vittorio, and they're in my very wonderful visit I had at the King's Dubai in earlier this year. And long may it continue. And I'd like to again thank everybody who put all of this webinar together. And I thank you for your attention.
Thank you very much, Ray. Wonderful presentation, as always. Lots of take-home messages. We certainly have here in the Middle East unmet needs in providing care for people with Parkinson's disease. And certainly there is a great need to increase the awareness of Parkinson with lots of educational opportunities. And I'm sure that between King's College Hospital in London and King's College Hospital London in Dubai, we will be able to close the gap and provide the local populations in the MENA region with what they need to get to get back to a kind of normality. And I also loved the ballet that we will probably import here in Dubai. I would like to...
Vittorio, there's one, I should thank the patient support group as well. I think they've been very...
Exactly.
The UAE Forum, I think really thank you for all the work you're doing and all the support. Thank you.
And I join you in thanking the UAE Genetic Disease Association, the Dubai Health Authority, the Emirates Neurological Society, and of course King's College Hospital in London and London in Dubai. And I would like to thank all the speakers for the fantastic presentation, very informative, very helpful. And we will be waiting for you here in King's College Hospital, London in Dubai. Now I hand the audience to Dr. Abu Bakr, consultant neurologist in Rashid Hospital and vice president of the Emirates Neurological Society. Abu Bakr, back to you. Thank you very much for being part of this forum.
Thanks, speakers. Thanks, Dr. Chaudhry. Thanks, Anna, for your nice presentation. I'm going to be translating briefly what you guys said in a few minutes. السلام عليكم ورحمة الله. شكرا للحضور على وجودكم لحد الآن في الوقت هذا المتأخر. بحاول ألخص ما قرأته الممرضة أنا والدكتور روي تشودري في المحاضرتين هذه في أقصر وقت. ملخصا في الحالات المتقدمة للباركنسون ديزيز في أنا لخصت في علاج واحد بس. أنا بركز لكم على 3 علاجات موجودة. في حالات الباركنسون المتقدمة شو يصير؟ لأن الجهاز الهضمي ما يصير امتصاص فيه الأدوية بشكل سليم، بتحتاج لعلاج آخر. من إحدى العلاجات اللي استخدمت هي يسمونها مضخة الديودوبا. فشو يصير فيها؟ تصير فتحة صغيرة في قناة الاثنى عشرية في المعدة، مما يتسرب فيها المضخة ويدخل فيها الديودوبا، دواء الديودوبا بالبطن أو في الاثنى عشر بشكل تلقائي. في هذه الحالة يسهل أو يتيح فيها استمرارية وجود الدواء في الدم بشكل مستمر، بعكس المرضى اللي يعطونهم أدوية. شو يصير؟ ياخذ الدواء ويتم الدواء لمدة معينة أو ما يمتص فيها بشكل مستمر، يكون العلاج أو الفعالية ما تكون بالقدرة المناسبة للمريض هذا. فالمضخة هذه تسهل من عملية العلاج، وكذلك يسهل من الحركة، وكذلك يسهل من المضاعفات موجودة إذا المريض يأخذ الأدوية. في علاجات ثانية مثل ما يسمونها الأيبومورفين بامب أو الأيبومورفين، مضخة الأيبومورفين. هذا يصير بشكل أسهل، تكون إبرة تحت الجلد يحطون فيها، وفي تحت الجلد يصير فيها سائل الأيبومورفين بشكل مستمر لمدة تقريبا 18 ساعة في اليوم، مما يسهل كذلك استمرارية استخدام الدواء المضخة هذه. فهذا هو العلاج الثاني. العلاج الثالث اللي ما تم ذكره بس أنا أحب أنوه عليكم، زرع شريحة في الدماغ، مما يتم فيها تحفيز الخلايا الدماغية ويساعد في هذه الحالة على سهولة الحركة عند المريض. هذه 3 علاجات الرئيسية الموجودة في مرض الباركنسون المتقدم. دكتور تشودري ذكر بشكل دقيق شو المضاعفات اللي تصير فيها في حالات الكوفيد، في حالات الكورونا، مما لا شك فيه معروف الحين عندنا نحن في أطباء الأعصاب أن مرض الكورونا قد يأثر على الدماغ أو النخاع الشوكي. كيف يأثر فيها؟ أول ما تحس أن المريض عنده صعوبة في الطعام أو صعوبة في الشم، هناك لازم نشك أنه ممكن يكون هذا هو قد يكون التهاب الكورونا مصاب بهذا المريض. عن طريق الخشم أو عن طريق الدماغ ممكن ينتقل الأعضاء الثانية في الدماغ، يسبب مشاكل كمشاكل الحركة، مشاكل التوازن، مشاكل التنميل. وبالذات في مرضى الباركنسون قد يتفاقم هالموضوع عندهم، وإذا بالذات إذا صار من الكورونا أو الكوفيد يصير لهم مشكلة في الشم، قد يكون مزمن بعض الأحيان. كذلك ممكن تتفاقم أعراض الحركة عندهم، أعراض التصلبات والآلام بالذات. فلذا ممكن في هذه الحالات يحتاجون علاجات مثل المضخة اللي ذكرناها، أو في بعض الأحيان التحفيز الكهربائي. مهم جدا في الحالات هذه بالذات إذا صار صعوبة في الشم أو صعوبة في التذوق، لازم الواحد يفكر في إذا الإنسان هذا مصاب بمرض الكوفيد أو الكورونا أو لا. شكرا جزيلا. Thank you very much. I translated most of your talks in few minutes. And the words for Dr. Victoria.
Thank you very much, Dr.
Hey,
Abubakar.
that's a very fantastic translation. Thanks very much, Dr. Abubakar, for your efforts.
Thank you very much. I think the time has come now to introduce the man himself. He has been the sufferer of this disease. I know him personally. He has been suffering from this from a very young age.
And very, very selflessly, he has been there untiringly for the society, just for the community, doing whatever he can. And he has been very instrumental in today's forum. The founder of Friends of Parkinson's UAE, Mr. Huzaifa Ibrahim. Mr. Huzaifa Ibrahim.
بسم الله الرحمن الرحيم. Assalamu alaikum. Good evening, everyone. Today, indeed, it is a historic. It's a day that none of us is going to forget. It's a day that all of us are going to remember. This is the day where we start a journey of helping everyone. This is a journey which is the first time it's being started in the UAE. First of all, I would like to thank all the departments that have supported today's forum and all the departments that have shown support to Friends of Parkinson's UAE. This time it's a special time which has never happened in the history. Because of COVID-19, all the medical teams that have been doing the great job everywhere, we really need to thank them. And we are really indebted to all the medical teams everywhere. As Sheikh Mohammed bin Rashid said, that all the citizens, every citizen and every resident in or on this land is indebted about their safety and about their well-being to the medical teams who have been working day and night without stop. So hats off to them, and I thank each and everyone for everything that they have done. Coming to Friends of Parkinson's UAE, the reason why it was started is because I did not want anyone to suffer the way I did, the way my family did. This is something that no one else can feel, because this is something that I have gone through it. How can a person like me, who was misdiagnosed, depressed, and felt wasted, there has to be a way should be out for all these things. And I wanted to provide more awareness to the community. And today, the support that everyone has shown, starting from Her Excellency Dr. Mariam, going on to the chairpersons and the esteemed international speakers who joined us, and all of you delegates. I would like to ask all your support to add your innovations, work as a team, and move together for Parkinson's. Last but not the least, I would like to extend my personal invite on behalf of Friends of Parkinson's UAE to all the esteemed speakers who joined us today to come and visit us in the United Arab Emirates. Thank you so much. Thank you.
Dr. Abu Bakr, would you like to translate this?
Yes, thank you very much everyone. بالنيابة عن جمعية أطباء الأعصاب أشكر الحضور على الاهتمام والمبادرة في اليوم العالمي للأعصاب. أتمنى أن تكونوا استمتعتم واستفدتم من محاضرات الليلة، وخاصة بالشكر الأخ حذيفة على إنشاء جمعية أصدقاء مرضى الباركنسون، وأتمنى من الحضور والمرضى مشاركة الأخ حذيفة في عمله وإنشاء مجموعة أكبر من المرضى، بالذات لاستثمار جمعية أصدقاء المرضى بآراء وأفكار جيدة قيمة. أتمنى كذلك بعض المرضى والأطباء في المشاركة في المرات القادمة لإثمار الأيام أو اليوم العالمي للأعصاب أو للباركنسون بشكل جيد. In behalf of Emirates Neurology Society, I thank everyone for attending this big day of World Brain Day, World Parkinson Day, whatever. And I'm hoping that this lecture has enriched us and all the audience with more information and innovations. And I thank particularly Mr. Hudayfa for establishing a patient support group for Parkinson. And I encourage all the audience, patients or relatives to share with Hudayfa his opinions and share with them with more opinion innovations. And thank once more everyone for this day.
Thank you, Dr. Abu Bakr. Thank you. On behalf of Friends of Parkinson's UAE, I would like to thank all of you. I would like to thank all the chairpersons. I would like to thank the speakers. I would like to thank the delegates, and most of all, Her Excellency, to be here with us this evening, and we look forward to your support. Thank you very much. We meet you again in the next event, inshallah. Thank you.
Thank you very much. Thanks for having us. Thank you.
Thank you. Have a good evening, everyone.